One, there exists a form of slavery in contemporary America that is rarely discussed, rarely acknowledged, yet affects tens of millions of people. It is not slavery in the traditional sense. There are no chains, no auction blocks, no slave traders, but it is slavery nonetheless. It is a system where people are bound by debt that they cannot escape, where their labor is extracted to service that debt, where their freedom is constrained by economic coercion. This form of slavery is medical debt slavery, and it is embedded deep within the American healthcare system. The United States is the wealthiest country on earth. It has advanced medical technology, world-class hospitals, brilliant physicians, and medical research capabilities unmatched anywhere in the world. Yet ordinary Americans face a healthcare system that is fundamentally broken. People delay seeking medical care because they fear the cost. People declare bankruptcy because of medical bills. People die from treatable conditions because they cannot afford treatment. People work jobs they hate, stay in abusive relationships, or endure other forms of suffering because they cannot risk losing their health insurance. The American healthcare system has become a mechanism of control and exploitation, binding people through medical debt into forms of servitude. The statistics on medical debt in America are staggering. Approximately 41 million Americans carry medical debt. The average amount of medical debt per person is around $2,500, but many people carry far more. Medical debt is the leading cause of personal bankruptcy in America. Studies suggest that approximately 60% of all personal bankruptcies in America involve medical bills. Medical debt is often unpayable. It accrues interest. It is sold to debt collectors. It destroys credit scores. It follows people for decades. Medical debt is not like other forms of debt. It is debt incurred for the purpose of staying alive, debt incurred in situations of medical crisis when people have no choice but to accept whatever terms are offered. The question that haunts any examination of medical debt in America is, how did a wealthy nation develop a healthcare system where ordinary people are enslaved by medical debt? How did a system emerge where people must choose between medical care and financial ruin? How did a system emerge where people's freedom is constrained by fear of medical bills? The answer requires understanding the history of American healthcare, the ideology of profit-driven medicine, and the structure of economic coercion that binds people through medical debt. To understand medical debt slavery in America, we must begin by understanding that the United States has a unique healthcare system among wealthy nations. Other wealthy countries, Canada, the United Kingdom, Germany, Japan, Australia, have universal healthcare systems where healthcare is funded through taxes and provided to all citizens. These systems are not perfect, but they do not trap people in medical debt. In these countries, you can see a doctor or go to a hospital without fear of bankruptcy. The United States, by contrast, has a profit-driven healthcare system where healthcare is a commodity to be bought and sold. Healthcare is provided primarily through for-profit insurance companies and for-profit hospitals. Healthcare is financed through a combination of employer-sponsored insurance, government programs, Medicare and Medicaid, and out-of-pocket payments. People without insurance or with inadequate insurance face enormous costs for medical care. This system did not emerge accidentally. It emerged through deliberate choices made by political and economic elites who prioritized profit over human welfare. In the 1940s and 1950s, when many other wealthy countries were establishing universal healthcare systems, the United States chose a different path. The American Medical Association, representing physicians, opposed national healthcare, fearing it would reduce their income. Insurance companies supported a system where they would be intermediaries between patients and healthcare providers, extracting profit. Large corporations supported employer-sponsored insurance because it gave them control over workers. Workers would fear losing their jobs because losing their job meant losing health insurance and access to health care. The result was a system designed to maximize profit for insurance companies, pharmaceutical companies, hospitals, and physicians. This system succeeded in generating enormous profits. Healthcare spending in America is approximately $4.5 trillion annually, roughly twice the per capita spending of other wealthy countries. Americans pay far more for healthcare than people in other wealthy countries, yet health outcomes are often worse. Life expectancy in America has actually declined in recent years due to opioid overdoses, suicide, and other deaths of despair. To understand how medical debt slavery functions, we must understand the mechanisms through which debt is imposed on people. Medical debt begins when a person seeks medical care. A person experiences a health emergency, a heart attack, an accident, a sudden illness, or needs ongoing care for a chronic condition. They go to a hospital or clinic. They receive care, they receive a bill. The bill for medical care in America is often astronomical. A night in a hospital can cost $5,000 to $10,000 or more. An emergency room visit can cost $1,000 to $5,000 just for the facility. Blood tests, imaging, X-rays, MRI, CT scans, medications, and procedures add to the cost. A person who spends one night in a hospital and receives several tests and procedures can easily receive a bill for $20,000 to $50,000 or more. These prices are not based on the actual cost of providing care. A hospital bed does not cost $5,000 per night to provide. A blood test does not cost $500. These prices are inflated far beyond the actual cost. The inflation serves to maximize revenue and profit. How are these inflated prices set? Hospital prices are often determined through negotiations between hospitals and insurance companies. Insurance companies negotiate with hospitals for discounted rates, but uninsured people and people with inadequate insurance have no negotiating power. They pay the full inflated price. The result is that uninsured people often pay far more for the same care than insured people. When a person receives a medical bill, they face a choice. They can pay it, go into debt, or declare it uncollectible. Many people cannot pay the bill immediately. They make partial payments. The unpaid balance accrues interest. The bill grows. If the person cannot pay, the bill may be sold to a debt collection agency. The debt collector then pursues the person to collect the debt. If the person still cannot pay, they may declare bankruptcy, or the debt may simply be uncollectible. But even uncollectible medical debt has consequences. It damages credit scores. It makes it harder to get loans, rent housing, or find employment. It follows the person for years. Even if the debt is eventually discharged through bankruptcy, it remains on the person's credit report for 7 years, affecting their financial life. This is the mechanism of medical debt slavery. A person experiences a medical crisis and receives care. They receive a bill they cannot afford to pay. They go into debt. The debt constrains their freedom. They cannot leave a job because they need the health insurance. They cannot take risks because they need to maintain income to pay the debt. They cannot make other financial decisions because they are bound by the debt obligation. Medical debt slavery has profound impacts on people's lives. People delay or avoid seeking medical care because of fear of debt. Studies show that approximately 26% of Americans have delayed or not sought needed medical care due to cost concerns. This means that roughly 1 in 4 Americans are choosing not to receive medical care they need because of cost. The consequences include disease progression, complications, and sometimes death. Consider a person with diabetes who cannot afford insulin. They delay seeking care. Their blood sugar becomes uncontrolled. They develop complications: kidney disease, vision problems, foot problems. By the time they receive care, the complications are severe and more expensive to treat. If they had received regular care and insulin, the complications could have been prevented. But the cost of regular care was prohibitive, so they avoided it until crisis occurred. Or consider a person with chest pain who delays seeking care because they fear the cost of an emergency room visit. They might have a heart attack. The heart attack requires emergency care and hospitalization, far more expensive than the initial evaluation would have been. But by avoiding the initial care due to cost concerns, they ended up requiring more expensive emergency care. Medical debt slavery also constrains people's labor mobility. A person might want to leave a job because the job is abusive, exploitative, or unfulfilling, but they cannot leave because leaving the job means losing employer-sponsored health insurance. They are trapped in the job by fear of losing health insurance. This gives employers enormous power over workers. Employers know that workers cannot easily leave because of health insurance, so they can exploit workers with confidence that workers will remain. This is particularly true for workers with chronic illnesses or disabilities. A worker with diabetes, for instance, cannot easily change jobs because they need consistent health insurance to pay for diabetes care. The employer knows this and can exploit the worker's dependence on the job for health insurance. The worker's freedom to choose is constrained by medical debt and the fear of losing health insurance. Medical debt also affects family relationships and creates impossible choices. When a family member becomes seriously ill, the family faces enormous medical bills. They must decide how to pay. Do they sacrifice other needs, housing, food, education, to pay medical bills? Do they go into debt? Do they let the medical debt go unpaid? Families are torn apart by these impossible choices. Parents skip meals to pay for their children's medical care. Children feel guilty for costing their parents money. Relationships are strained by the financial stress. To understand how medical debt slavery persists despite being widely recognized as a problem, we must understand the political economy of American healthcare. Healthcare in America is not primarily designed to promote health. It is designed to generate profit. Decisions about healthcare policy are made not by doctors or public health experts, but by insurance companies, pharmaceutical companies, hospital administrators, and politicians influenced by healthcare industry lobbying. The healthcare industry is one of the largest industries in America. It generates trillions of dollars in revenue annually. The industry is composed of multiple sectors: insurance companies, pharmaceutical companies, hospitals, medical device manufacturers, and others. Each sector has powerful financial interests. Insurance companies profit by collecting premiums and denying care. The more premiums they collect and the fewer claims they pay, the more profit they make. Insurance companies have incentives to deny claims, to impose high deductibles, to narrow networks of covered providers, and to impose other restrictions on care. These practices increase profit for insurance companies but harm patients. Pharmaceutical companies profit by selling drugs at the highest possible price. Pharmaceutical companies charge far more for drugs in America than the same drugs cost in other countries. A drug that costs $10 in Canada might cost $100 in the United States. The difference is pure profit for the pharmaceutical company. Pharmaceutical companies have invested heavily in lobbying to prevent price regulation and to extend patent protections. Hospital systems have consolidated into large corporate entities that prioritize profit. Hospital administrators earn enormous salaries, often millions of dollars annually. Hospital systems purchase medical practices and integrate them into corporate hospital networks. Hospitals employ billing specialists whose job is to extract maximum revenue from patients and insurance companies. Hospitals mark up prices far beyond the actual cost of care. All of these entities have financial interests in maintaining the status quo. They profit from medical debt, from inflated prices, from restricted access to care. They have invested heavily in lobbying Congress to prevent healthcare reform. They have financed political campaigns to ensure that healthcare policy reflects their interests rather than the interests of patients. The result is a healthcare system designed to extract maximum revenue from patients while providing minimum care. This is not a side effect of the system, it is the system's purpose. To understand the political economy of medical debt slavery, we must understand the role of insurance companies. Insurance companies are central to American healthcare. The vast majority of Americans receive healthcare through insurance companies. Insurance companies decide which treatments are covered, which are not, how much patients must pay out of pocket, which doctors patients can see, and other crucial aspects of healthcare access. Insurance companies are profit-driven corporations. They are not required to maximize health outcomes. They are required to maximize shareholder returns. This creates a fundamental conflict of interest. Healthcare that maximizes shareholder returns is not necessarily healthcare that maximizes patient health. Insurance companies employ teams of bureaucrats whose job is to deny claims. These employees are often called utilization reviewers or prior authorization specialists. Their job is to evaluate whether treatments ordered by doctors are medically necessary and therefore covered by insurance. In many cases, they deny treatments that doctors have recommended. Patients appeal these denials. Some patients exhaust their appeals and give up, going without needed treatment. Some patients receive treatment anyway but have to pay out of pocket because the insurance company denied coverage. Insurance companies have financial incentives to deny claims. Each claim denied is money the insurance company does not have to pay out. Insurance companies can thus increase profits by denying more claims. This creates a perverse incentive structure where insurance company bureaucrats profit from preventing people from receiving needed care. Insurance companies also control access through high deductibles, copayments, and coinsurance. A person might have health insurance but face a $5,000 annual deductible. This means they must pay $5,000 out of pocket before insurance coverage begins. For a person earning $30,000 annually, a $5,000 deductible is prohibitive. Many people with high deductible plans effectively have no insurance. They cannot afford to pay the deductible, so they avoid seeking care. Insurance companies also restrict access through narrow networks. Insurance companies contract with certain providers and exclude others. A person might have insurance but discover that their preferred doctor or hospital is not in their insurance network. They must either pay out of pocket to see the provider or choose a different provider. This gives insurance companies power to direct patients to certain providers and away from others. To understand medical debt slavery, we must understand the role of pharmaceutical companies. Pharmaceutical companies charge exorbitant prices for drugs, and these high prices drive medical debt for millions of Americans. Pharmaceutical companies justify high drug prices by arguing that drug development is expensive and that high prices are necessary to fund research and development. There is some truth to this. Drug development does cost billions of dollars. But pharmaceutical companies' prices are far higher than necessary to cover development costs and generate reasonable profit. Pharmaceutical companies charge what the market will bear, as much as they can extract from patients, insurance companies, and government programs. The result is that Americans pay far more for drugs than people in other wealthy countries. Insulin, which costs approximately $10 to produce, is sold in America for $200 to $400 per vial. People with diabetes face impossible choices: pay for insulin or pay for other necessities. Some people ration insulin, taking less than prescribed to make their supply last longer. This causes blood sugar to become uncontrolled, leading to complications. Pharmaceutical companies have lobbied intensively to prevent government price regulation. The Medicare prescription drug benefit, passed in 2003, specifically prohibited Medicare from negotiating drug prices. This means that the federal government, despite spending trillions of dollars on healthcare, cannot negotiate lower prices for drugs. Pharmaceutical companies have actively lobbied Congress to maintain this prohibition. Pharmaceutical companies have also extended patent protections for drugs through various mechanisms. When a drug's patent expires, generic versions can be produced at far lower cost. To delay this, pharmaceutical companies make minor modifications to drugs, changing the formulation, the delivery mechanism, or the dose, and obtain new patents. They market the new version extensively while discouraging the use of the older, cheaper version. Patients are switched to the new version not because it is significantly better, but because the pharmaceutical company has marketed it aggressively, and the old version has gone out of production. This practice, called evergreening, allows pharmaceutical companies to maintain high prices by preventing generic competition. The result is that Americans spend far more on pharmaceuticals than people in other wealthy countries, and many Americans cannot afford the drugs they need. Medical debt from pharmaceutical costs drives many Americans into debt. To understand medical debt slavery, we must understand the role of hospitals. Hospitals in America charge inflated prices for services, and these prices drive medical debt. Hospital prices are not based on the actual cost of providing services. A hospital might charge $500 for a blood test that costs $20 to perform. A hospital might charge $5,000 per night for a hospital bed that costs $1,000 per night to maintain. These inflated prices generate enormous profit for hospital systems. Hospital systems have consolidated dramatically in recent decades. In the 1980s, there were many independent hospitals. Today, most hospitals are part of large hospital systems controlled by for-profit corporations or large nonprofit systems that operate with profit-maximizing logic. These large hospital systems have market power to charge higher prices. When hospital systems consolidate in a geographic area, competition declines, and hospitals can charge higher prices with less fear of losing patients to competitors. Hospital systems employ sophisticated billing departments designed to extract maximum revenue from patients and insurance companies. Hospitals use complex billing codes to maximize charges. They charge separately for items that might be bundled together in other contexts. They charge for services that patients did not know they would be charged for. The result is that patients receive bills with hundreds or thousands of line items, many of which are unclear or duplicative. Hospital systems also employ debt collection practices designed to coerce payment. If a patient cannot pay a hospital bill, the hospital may sell the debt to a debt collection agency. The debt collector pursues the patient aggressively. The debt collector may threaten wage garnishment, bank levies, or other coercive measures. The debt collector may contact the patient's employer or family members. The debt collector may pursue the patient for years. Many debt collectors violate debt collection laws, but enforcement of debt collection law is minimal, so violations are rampant. Some hospital systems have pursued legal actions against patients to collect medical debt. They have obtained judgments against patients allowing wage garnishment or bank levies. This coercive debt collection practice has been documented extensively by researchers and journalists. The result is that patients who cannot pay medical bills have their wages garnished or bank accounts levied, reducing their income and constraining their ability to meet other obligations. To understand medical debt slavery, we must understand how medical debt traps people in poverty. Medical debt is often unpayable, and attempts to repay it can create a spiral into deeper poverty. A person incurs medical debt through a medical crisis. Let us imagine a person earning $30,000 annually who has a heart attack and is hospitalized for 3 days. The hospital bill is $100,000. The person has health insurance but only covers 80% after the deductible. The person's share is $20,000. The person cannot pay $20,000 immediately. They negotiate a payment plan with the hospital. They agree to pay $500 per month. This will take 40 months, more than 3 years, to repay. During this time, the person is spending $500 per month on medical debt repayment instead of on other needs. But what if the person has other medical issues? What if they need medications, follow-up appointments, physical therapy? These additional medical costs add to the debt. The person's medical debt grows to $30,000, $40,000 or more. Meanwhile, the person is still earning $30,000 annually. After taxes, the person nets approximately $24,000 annually or $2,000 monthly. After spending $500 on medical debt, they have $1,500 monthly for housing, food, transportation, childcare, utilities, and all other expenses. This is insufficient. The person falls behind on other bills, rent, utilities, car payments. The person now has multiple debts: medical debt, housing debt, utilities debt. If the person misses payments on any debt, creditors pursue collection, wage garnishment occurs, bank accounts are levied, credit scores decline. The person becomes trapped in a spiral of poverty and debt. The person might declare bankruptcy. If they declare bankruptcy, the medical debt might be discharged, but bankruptcy itself has severe consequences. It destroys credit scores and makes it difficult to borrow for years. This spiral is not accidental. It is built into the structure of medical debt. Medical debt is often uncollectible. People simply do not have the income to repay it. Yet debt collectors pursue collection aggressively anyway. The result is that people are trapped in poverty by medical debt. To understand medical debt slavery, we must examine specific cases of how medical debt has destroyed lives. These are not abstract statistics. They are real people experiencing real suffering. Consider a woman in her 40s who developed breast cancer. She went through chemotherapy, surgery, and radiation. She accumulated $200,000 in medical debt. She had health insurance, but her insurance coverage had limits. After exhausting her insurance coverage, she had to pay out of pocket for additional treatments. She borrowed money from family members. She took out personal loans. She used credit cards. She depleted her savings. Years after her cancer treatment, she was still paying medical debt. She was earning $50,000 annually, but $500 per month of her income was consumed by medical debt payments. She could not save money. She could not go on vacation. She could not help her children with college costs. She lived in fear of another medical crisis that would push her deeper into debt. Or consider a man in his 50s who had a heart attack and was hospitalized for a week. His medical bill was $150,000. He had employer-sponsored insurance, but after paying his premium, deductible, and coinsurance, he owed $30,000. He did not have $30,000. He could not afford to pay. He negotiated a payment plan but could not maintain payments. His wages were garnished. His bank account was levied. He declared bankruptcy. After bankruptcy, his credit score was destroyed. He could not get a loan. He had to pay higher insurance premiums. He had to pay higher deposits for utilities. Everything was more expensive because of his bankruptcy. 20 years later, bankruptcy was still affecting his life. Or consider a young woman who had a car accident and was hospitalized. Her medical bill was $50,000. She did not have health insurance. She was young and had thought she did not need it. She incurred the full $50,000 bill. She could not pay it. Debt collectors pursued her aggressively. She fell into depression. She considered suicide. She eventually paid most of the debt through wage garnishment, but the debt constrained her entire life. She could not move to a new city for a better job because the debt collector was pursuing her. She could not take risks. She was trapped. These stories are not unique. Millions of Americans have similar stories. They have experienced medical crises, accumulated medical debt, and spent years or decades trying to repay unpayable debt. To understand medical debt slavery, we must understand how medical debt intersects with other forms of inequality and creates compounding effects. Medical debt disproportionately affects poor people and people of color. Poor people have less access to preventive health care, so they experience more serious health problems. Poor people have less access to insurance, so they must pay more out of pocket for health care. Poor people have less income, so they are less able to repay medical debt. People of color also disproportionately experience medical debt. Racial disparities in healthcare access, quality of care, and health outcomes mean that people of color experience more serious health problems. Racial disparities in income mean that people of color have less income to pay for health care. Racial disparities in wealth mean that people of color have less savings to draw on when facing medical debt. Medical debt also intersects with gender inequality. Women experience more healthcare costs because of gender-specific conditions: pregnancy, menopause, breast cancer, gynecological conditions. Women's lower average income means they are less able to repay medical debt. Single mothers are particularly vulnerable to medical debt. They have the full responsibility for supporting their children on a single income while facing healthcare costs related to their own health and their children's health. Medical debt also intersects with age-related inequality. Older people experience more health problems and higher healthcare costs. Many older people are on fixed incomes, Social Security, which limits their ability to repay medical debt. Some older people have accumulated medical debt over decades and have limited time to repay it before death. Medical debt also intersects with disability. People with disabilities face higher healthcare costs due to ongoing care needs. People with disabilities often have lower income due to discrimination in employment. The combination of higher costs and lower income makes medical debt particularly burdensome for people with disabilities. The result of these intersections is that medical debt disproportionately affects the most vulnerable people in American society: poor people, people of color, women, older people, and people with disabilities. Medical debt deepens existing inequalities and makes it harder for vulnerable people to escape poverty. To understand how medical debt slavery persists, we must understand the role of ideology. The American healthcare system is justified through an ideology that emphasizes individual responsibility and market efficiency. According to this ideology, people should be responsible for purchasing their own health insurance and paying for their own healthcare. Healthcare should be provided through markets, not government. Prices should be set by supply and demand, not government regulation. This ideology ignores the reality that healthcare is not a normal market good. People do not shop for healthcare the way they shop for other goods. Medical emergencies do not allow time for comparison shopping. People cannot easily compare prices for medical procedures. Medical conditions are often unpredictable and uncontrollable. A person cannot choose to not have a heart attack or a cancer diagnosis. The market ideology also ignores power asymmetries. Healthcare providers, hospitals, doctors, pharmaceutical companies have far more power than patients. Patients are vulnerable and desperate when seeking healthcare. Healthcare providers exploit this vulnerability by charging high prices. The market ideology suggests that competition will keep prices down, but in healthcare, competition has not kept prices down. Healthcare prices have soared despite existing competition. The market ideology also ignores the reality that people cannot live without healthcare. Healthcare is a necessity for survival, not a luxury good. A person cannot choose to not consume healthcare the way they can choose to not consume other goods. This removes the market mechanism that supposedly prevents excessive prices. Yet the market ideology persists because it serves the interests of healthcare industry corporations. Insurance companies, pharmaceutical companies, hospitals, and other healthcare industry entities have promoted this ideology through political lobbying, media campaigns, and funding of academic research. The ideology justifies their high prices and profits. If healthcare is a market good and prices are set by supply and demand, then high prices are justified as reflecting the natural market value of healthcare. The ideology also shifts responsibility from the healthcare industry to individuals. If people cannot afford healthcare, it is because they have not taken enough responsibility. They have not worked hard enough to earn more income, they have not purchased adequate insurance, they have not made healthy lifestyle choices. The healthcare industry bears no responsibility for high prices or lack of access. Individuals bear all responsibility. This ideology has been remarkably effective in justifying the status quo. Despite widespread suffering from medical debt, despite international comparisons showing that American healthcare is more expensive and less effective than healthcare in other wealthy countries, despite overwhelming evidence that the American healthcare system is fundamentally broken, the market ideology persists. The healthcare industry has successfully convinced many Americans that the market-based system is the best available option, and that reform is impossible or undesirable. To understand how medical debt slavery is enforced, we must understand the role of debt collection. Medical debt is often collected aggressively through practices that violate the humanity and dignity of debtors. Debt collectors pursue medical debt aggressively because medical debt is often highly profitable. A debt collection agency might purchase medical debt for pennies on the dollar. If someone owes a hospital $10,000 in medical debt that is uncollectible, the hospital might sell the debt to a debt collection agency for $1,000. The debt collection agency then pursues the debtor. If the agency successfully collects any money, they keep it as profit. Debt collectors use various coercive tactics to pursue collection. They contact debtors repeatedly by phone. They send threatening letters. They file lawsuits. They pursue wage garnishment and bank levies. They contact employers, family members, and friends. They threaten legal action and jail time even though debtors cannot be jailed for owing money in most circumstances. Debt collectors often violate the Fair Debt Collection Practices Act, which prohibits certain collection practices. They call debtors repeatedly after being asked to stop. They call debtors before 8 a.m. or after 9 p.m. They call debtors at work even after being asked not to. They misrepresent their authority, claiming they represent lawyers or courts when they do not. They make threats that are illegal. They disclose debts to third parties. Despite these violations, enforcement of the Fair Debt Collection Practices Act is minimal. Debt collectors know they can often violate the law with little risk of punishment. The impact of debt collection on debtors is severe. Debtors experience stress, anxiety, and depression. The constant phone calls and threatening letters create psychological torment. Some debtors experience health problems related to debt collection stress. Some debtors consider or attempt suicide. Some debtors are driven to extreme measures, taking jobs off the books, moving frequently, changing identities to escape debt collection. Wage garnishment is a particularly effective debt collection mechanism because it removes money directly from the debtor's paycheck. The debtor never has a chance to receive the money and decide whether to pay the debt or pay other obligations. The money is simply taken. This can create severe financial hardship. A person living paycheck to paycheck might have their wages garnished, leaving insufficient income to pay rent or buy food. Bank levies are another debt collection mechanism where a debt collector obtains a court order allowing them to seize money from the debtor's bank account. Again, the money is taken directly without the debtor's consent. If a debtor is living paycheck to paycheck and their bank account is levied, they might not have money to pay rent or buy food. To understand how medical debt slavery affects the broader economy and society, we must understand the macroeconomic impacts of widespread medical debt. Medical debt constrains consumer spending. Money spent on medical debt cannot be spent on other goods and services. This reduces aggregate demand in the economy, which reduces economic growth. Studies suggest that medical debt reduces consumer spending by billions of dollars annually. Medical debt also constrains saving and wealth accumulation. People burdened with medical debt cannot save money for emergencies, retirement, or other purposes. They cannot invest in education or other forms of human capital. Medical debt thus perpetuates poverty and reduces intergenerational mobility. Medical debt also affects housing. People with medical debt have lower credit scores, which makes it harder to obtain mortgages. People struggling with medical debt may not be able to save a down payment for a house. People with medical debt are more likely to be evicted from rental housing if they cannot pay rent due to medical debt obligations. Medical debt thus contributes to housing instability and homelessness. Medical debt also affects education. Young people burdened with medical debt from healthcare costs may not be able to afford college or may need to take on additional educational debt. Parents struggling with medical debt may not be able to support their children's education. Medical debt thus constrains educational opportunity and perpetuates inequality. Medical debt also affects family formation. Young people may delay marriage, having children, or other major life decisions because of medical debt. Medical debt creates stress in relationships and is a leading cause of divorce. Medical debt thus has effects that extend beyond the individual debtor to affect families and communities. Medical debt also affects workforce productivity. Workers burdened with medical debt experience stress, anxiety, and health problems. This reduces productivity. Workers may miss work due to health problems or due to debt collection activities. Workers may be less engaged and motivated if they are struggling with medical debt. This reduces economic output. Medical debt also increases healthcare costs. When people delay seeking care due to fear of medical debt, they develop more serious health conditions that require more expensive care. This increases overall healthcare spending. Medical debt thus creates a vicious cycle where debt constrains care seeking, which leads to more serious conditions, which leads to higher costs, which leads to more debt. To understand how medical debt slavery could be addressed, we must consider reforms that would reduce or eliminate medical debt. These reforms would require fundamental changes to the American healthcare system. One approach would be to establish a universal single-payer healthcare system. This would involve the government providing healthcare to all Americans through a single insurance program. This would eliminate medical debt for most people because healthcare would be funded through taxes, not through patient payments. This approach is used in many other wealthy countries and has been shown to reduce healthcare costs while improving health outcomes. Another approach would be to cap medical debt or eliminate it entirely. The government could prevent medical debt from being collected, requiring hospitals and other healthcare providers to absorb the costs of uncollectible medical debt. This would effectively eliminate medical debt. It would require changes to the law allowing medical debt to be uncollectible. Another approach would be to cap out-of-pocket healthcare costs. The government could require that people not be liable for more than a certain percentage of their income in medical costs. This would protect people from catastrophic medical debt while still maintaining a market-based system. Another approach would be to expand Medicaid and Medicare to cover more people and more services. This would reduce the number of uninsured people and reduce out-of-pocket costs for insured people. Another approach would be to regulate drug prices. The government could negotiate drug prices, set maximum prices, or use other mechanisms to ensure that drugs are affordable. This would reduce medical debt from prescription drugs. Another approach would be to regulate hospital and doctor prices. The government could set maximum prices for medical services or require hospitals and doctors to charge transparent, reasonable prices. This would reduce medical debt from hospital and medical provider charges. Another approach would be to provide debt relief for people burdened with medical debt. The government could forgive medical debt for people below certain income levels, or offer programs that reduce medical debt obligations. Each of these approaches faces obstacles. The healthcare industry would oppose reforms because reforms would reduce their profits. The insurance industry, pharmaceutical companies, and hospitals have invested heavily in lobbying to prevent reform. These industries have convinced many politicians that reform is impossible or undesirable. But these obstacles are not insurmountable. Other wealthy countries have implemented healthcare reforms that have worked. The obstacles are primarily political, not technical. To understand the human cost of medical debt slavery, we must recognize that medical debt is not simply a financial issue, it is a human issue. Medical debt represents the system's failure to meet basic human needs. Medical debt represents a choice to prioritize profit over human welfare. Medical debt means that people suffer and die from treatable conditions because they cannot afford care. Medical debt means that people are trapped in poverty and cannot escape no matter how hard they work. Medical debt means that people are constrained in their choices and their freedom because of fear of medical bills. Medical debt means that people experience constant stress and anxiety about their health and finances. Medical debt means that families are torn apart by financial strain related to healthcare costs. Medical debt means that children go without adequate healthcare because their families cannot afford it. Medical debt means that people work jobs they hate because they need the health insurance. Medical debt means that people endure abuse and exploitation because they cannot risk losing their jobs and their health insurance. Medical debt is not a symptom of individual failure or irresponsibility. Medical debt is a symptom of a fundamentally broken healthcare system that prioritizes profit over human welfare. Medical debt is a form of slavery because it constrains freedom through economic coercion. Medical debt is a form of violence because it causes suffering and death. To address medical debt requires not just treating the symptoms, providing debt relief or debt collectors, but addressing the root cause, which is a healthcare system designed to extract profit rather than promote health. This requires fundamental reform of the American healthcare system. The political obstacles to healthcare reform are substantial but not insurmountable. Polls consistently show that the vast majority of Americans support healthcare reform. Surveys show that people across the political spectrum support universal healthcare, price regulation for drugs, and other reforms. But despite this widespread support, reform has not occurred. Why? The answer is that the healthcare industry has deployed substantial resources to prevent reform. Insurance companies, pharmaceutical companies, hospitals, and medical device manufacturers have spent billions of dollars on lobbying. They have funded political campaigns, they have funded academic research, they have funded media campaigns, they have hired former politicians and government officials to represent their interests. This has created a situation where the healthcare industry's interests are well represented in Congress, while patients' interests are poorly represented. The healthcare industry has also successfully framed healthcare reform as government overreach, socialism, or un-American. This framing has prevented many Americans from supporting healthcare reform, even though they would benefit from it. The healthcare industry has convinced many Americans that the American healthcare system, despite being clearly broken, is preferable to alternatives. To overcome these obstacles would require a political movement strong enough to overcome the healthcare industry's lobbying power. This would require grassroots organizing, political pressure, and sustained commitment to reform. Some people are working to build such a movement. Activists, unions, and advocacy organizations are organizing for healthcare reform. Young people are becoming more supportive of major healthcare reforms, but building a political movement strong enough to overcome the healthcare industry's opposition remains extremely difficult. The COVID-19 pandemic revealed both the failures of the American healthcare system and the possibility for alternative systems. During the pandemic, the federal government deployed unprecedented resources to address the crisis. The government funded vaccine development. The government paid for testing and vaccination. The government funded expansion of hospital capacity. The government provided financial support to healthcare workers. The government acted as if healthcare was a matter of national importance that warranted substantial public investment. Yet immediately after the pandemic, the healthcare system reverted to its pre-pandemic structure. The government reduced its support for healthcare. Private companies resumed charging high prices. Insurance companies resumed denying coverage. Medical debt resumed accumulating. The pandemic demonstrated that government intervention in healthcare is possible and can work, but it also demonstrated that without sustained political will, government support for healthcare is temporary. Looking forward, the future of medical debt slavery in America remains uncertain. One possibility is that medical debt will continue to worsen as healthcare costs continue to rise. As healthcare costs increase, more people will face medical debt, and the amount of medical debt will increase. This would deepen poverty and constrain economic growth. Another possibility is that political reform will occur, and the American healthcare system will be fundamentally restructured. This would require overcoming the healthcare industry's political power, but it is possible. Many political movements have successfully challenged powerful industries. If such reform occurs, medical debt would be substantially reduced or eliminated. A third possibility is that medical debt will become even more coercive and predatory. Debt collection practices could become more aggressive. Wage garnishment and bank levies could expand. Incarceration of debtors could resume, technically illegal but happening in some jurisdictions. Medical debt could become even more of a form of enslavement. What is clear is that the current system is unsustainable. Medical debt is not a natural or inevitable feature of healthcare. It is a choice made by a society that has prioritized profit over human welfare. A different choice is possible. To understand medical debt slavery in the context of American capitalism, we must recognize that medical debt is not unique. It is one manifestation of a broader system of debt-based coercion and control. Student debt is another form of debt slavery. Millions of Americans are trapped by student debt. They cannot afford housing, cannot start families, cannot take risks because of student debt. Like medical debt, student debt is often unpayable and follows people for decades or their entire lives. Credit card debt is another form of debt slavery. Millions of Americans are trapped by credit card debt, often at interest rates exceeding 20%. They cannot escape the debt because the interest is so high. Mortgage debt, while not always exploitative, can also become a form of debt slavery if housing prices are too high relative to incomes. People can become trapped in houses they cannot afford, unable to move or make other life decisions. Payday loan debt is another form of debt slavery. Poor people borrow money at extremely high interest rates, often 300% or more, and become trapped in cycles of borrowing and debt. All of these forms of debt share a common feature. They constrain freedom through economic coercion. People cannot make the choices they would prefer because they are bound by debt. People must accept exploitative working conditions because they need income to service debt. People must live in fear of default because default has severe consequences. Medical debt slavery is one manifestation of a broader American capitalism that relies on debt to bind and control people. Addressing medical debt slavery requires not just healthcare reform but broader economic reform that reduces reliance on debt as a mechanism of control. The story of medical debt slavery in America is ultimately a story about the failure of a system designed to prioritize profit over human welfare. It is a story about how a wealthy country has developed a healthcare system where people are enslaved by medical debt. It is a story about how millions of people suffer and die because they cannot afford care. It is a story about how a political and economic elite has prioritized their wealth and power over the well-being of ordinary people. But it is also a story that is not yet finished. The future of American healthcare is not predetermined. A different future is possible. A future where healthcare is treated as a right, not a commodity. A future where no one goes into medical debt. A future where everyone has access to the care they need. A future where healthcare is designed to promote health, not maximize profit. Building this future would require overcoming powerful opposition from the healthcare industry. It would require building a political movement capable of challenging that opposition. It would require sustained commitment to reform, but it is possible. And the alternative, continuing with a system that enslaves millions through medical debt, is unacceptable.